Okay, I want you to picture something for a second. We're going to start this innovation unpacked deep dive with a, well, a visualization exercise.
Sure, let's do it.
I want you to picture the ultimate, absolute gold standard model for healthcare. Like when you hear the buzzword value-based care thrown around by executives or politicians, what instantly pops into your head?
For most people, it's a very specific, very comforting image.
Right. If you're like most people trying to navigate this industry, or honestly, just anyone who has ever worried about a sick, aging parent, you probably imagine this highly trained, incredibly empathetic nurse, maybe a nurse practitioner, pulling up to your mother's driveway.
Yeah, walking up to the front door, providing care right there in the living room.
Exactly. They sit on the couch with the patient, they take their time, they check their blood pressure, they listen to their heart. Maybe they even walk over and, open the fridge to make sure there's fresh, nutritious food in the house.
They provide what the industry loves to call whole person care.
Yes, it sounds perfect, right? You look at that model and you think, finally, this is the compassionate, foolproof solution to everything broken and transactional in our medical system.
It does sound perfect on paper. I mean, the emotional resonance of that image is undeniable.
And this is a massive but.
But what's fascinating here, and frankly, deeply unsettling, is that according to the material we're analyzing today, that comforting image is completely mathematically wrong.
And by wrong, you don't mean their hearts are in the wrong place.
No, the clinical intentions are stellar. But the architecture of that model is structurally doomed.
Doomed. That's a strong word.
It's the accurate word.
Yeah.
Bringing that level of high-touch, human-driven care directly into the living room doesn't solve the macroeconomic healthcare crisis. In fact, it does the exact opposite.
It creates a bottleneck.
A fatal, unscalable bottleneck that is actively bankrupting the system from the inside out.
Which is such a massive paradigm shift. And
Yeah.
that is exactly why we are dedicating today's deep dive to unpacking this. Our mission today is to completely deconstruct the narratives, some might call them lies or at least very expensive fictions, that the healthcare industry tells itself about population health and scale.
We have our hands on a truly fascinating new dossier authored by Mike Boysen.
Right. It's titled Zero-Marginal-Cost, Value-Based Care. And it is wild.
It's an incredibly dense, rigorous piece of work. It takes the emotional assumptions we make about medicine and submits them to ruthless economic and physical scrutiny.
It pulls absolutely no punches. Over the next hour or so, we are going to explore what Boysen calls a radical structural inversion. We're going to look at how we can use invisible, zero-marginal-cost technology to actually save lives and keep people out of the hospital.
Rather than just throwing more exhausted, highly paid humans into city traffic.
Exactly. So let's start at the very foundation. Why is this current comforting model of in-home care so fundamentally broken?
If we pull back and look at the bigger picture, the stakes here are existential for the healthcare system. Right now, in the 2020s, we are attempting to run a 21st century predictive health enterprise.
Meaning we have cloud computing, AI, massive data sets predicting who is going to get sick.
Right. We have all that advanced intelligence, but we are forcing it to ride on a 19th century horse and buggy delivery chassis.
A horse and buggy delivery chassis. I love that phrasing. But let's break down what that actually means in the real world for you listening.
It means we have algorithms running in server farms that can predict, with startling accuracy, that a specific patient is going into heart failure. The technology works.
The prediction works?
Yes, but our delivery mechanism, the way we actually intervene to stop that heart failure, is a human being.
Right, a nurse driving a Honda Civic across town in rush hour traffic?
Trying to find parking just to manually wrap a blood pressure cuff around an arm.
When you say it out loud, the disconnect is glaring. We have quantum leaps in data, but our delivery is bottlenecked by physical asphalt.
And the fundamental math of this model guarantees a structural collapse. We are taking highly specialized, incredibly expensive medical professionals, and we are optimizing their car rides instead of their clinical minds.
Which is crazy. You cannot build a scalable, modern health system when your primary mechanism of delivery is governed by the speed of local traffic.
Exactly.
Okay, I want to dive straight into the first major concept from the manifesto, which is called the physics of failure. Because we need to be clear for everyone listening, we aren't just talking about a few small, struggling mom-and-pop clinics making this mistake.
No, we are talking about the absolute titans of the industry, the market leaders who are celebrated on the covers of business magazines.
The multi-billion-dollar players. Look at Cityblock Health. They raised over $850 million in venture capital, focusing heavily on Medicaid and dual-eligible populations.
Most vulnerable patients.
Right. They're building out these neighborhood hubs and deploying field teams. Or look at Oak Street Health. They were acquired by CVS for $10.6 billion. Billion with a B.
And ChenMed, which is famous for providing this VIP, high-touch, white-glove care model for seniors.
They cap their physician panels, meaning the number of patients a doctor is responsible for at around 400 patients instead of the crazy industry standard of 2,000 to 3,000.
And again, the clinical philosophy there is beautiful. Giving a doctor more time with fewer patients yields better individual interactions. But the dossier argues they are all inevitably slamming into a physical wall.
The author defines this wall as the denominator. Let's unpack the math of that.
In any basic equation of productivity, the denominator represents your limits, the fixed constraints that dictate your maximum possible output. In this value-based in-home care model, the physical floor of that denominator is travel time.
Let's look at the reality of that.
If you have a nurse practitioner, an NP, or a community health worker operating in a dense urban center like Chicago or New York,
Where it takes 45 minutes to go 3 miles on a Tuesday.
exactly. Or conversely, if they're operating in a sprawling rural county in Texas where patients are separated by 30 miles of dirt roads.
The friction is just different, but it's still friction.
Right. Physics dictates that this clinician can only physically complete about 4 to 6 in-home visits per 8-hour shift.
4 to 6 visits total for the entire day. That is so low.
That is the hard limit.
Yeah.
You cannot code your way out of a physical traffic jam.
You could have the most sophisticated AI scheduling software in the world, backed by quantum computers, but it cannot make a physical car move through a gridlocked intersection any faster.
Precisely. The speed of local traffic is the ultimate governor on your clinical capacity.
So the ceiling on your revenue and your impact is entirely dictated by the Department of Transportation.
It is. But that's just the physical floor. We also have to layer on the statutory floor.
The legal regulation.
Right. CMS, the Centers for Medicare and Medicaid Services, along with HIPAA regulations, mandate specific, highly documented, human-in-the-loop interactions for capitation and risk adjustment factor scoring.
Wait, let's pause and translate that for anyone who isn't an actuary. Capitation and RAF scores, what does that actually mean for the business side?
Capitation means the health plan pays the clinic a flat fee per patient per month, regardless of how many times the patient comes in. It's supposed to incentivize keeping the patient healthy.
Because if they stay healthy, you keep the profit. If they get sick, you eat the cost.
Exactly.
Okay.
But to adjust that flat fee so you get paid fairly for sicker patients, you have to prove to the government exactly how sick they are. That's the risk adjustment factor, or RAF score.
So if a patient has diabetes, heart failure, and depression, your RAF score goes up, and the government pays you more per month to manage that complex care. That makes sense.
It does. But you can't just guess their conditions, and you can't just wave at the patient from the doorway and say, looks fine to me.
The government wants proof.
The government mandates rigorous face-to-face assessment. The clinician has to sit down, conduct a comprehensive interview, review medications, and document every single detail meticulously in the electronic health record to justify that RAF score.
So the denominator is completely, absolutely fixed. 4 to 6 visits a day, period.
You cannot squeeze 10 visits in, because if you rush the visit, you fail the CMS documentation requirements, and your funding gets slashed.
Yeah.
You're boxed in by physics on one side and federal law on the other.
Okay, so that is the denominator. Now, here is where it gets really eye-opening for you listening. Let's look at the numerator, the cost required to maintain that fixed output.
The numbers laid out in this manifesto are staggering.
We are talking about fully loaded enterprise costs here. So not just take-home salary, but benefits, taxes, training, software licenses, overhead.
The true cost to the business to keep that person in the field.
Right. A community health worker, a CHW, or a doula costs the enterprise roughly $65,000 a year. That breaks down to about $31 an hour.
Yep.
A nurse practitioner or a physician assistant, they cost the enterprise about $140,000 a year, which is around $67 an hour. And then you have the L4 supervisors.
Let's define the L4 supervisor for context. In this model, you have tiers of care. L1 might be a medical assistant. L2 is a registered nurse.
Right.
L3 is your nurse practitioner.
For people on the ground.
Right. The L4 is the primary care physician, the MD or DO, who who has the highest level of licensure and ultimately signs off on the most complex clinical decisions and assumes the highest legal risk.
And according to the dossier, those L4 physicians are sitting at a fully loaded cost of $280,000 or more per year.
So you have this massive, heavy numerator of human labor costs.
And we have to contrast those fixed, exorbitant labor rates against the cost of systemic failure.
Exactly. Why are we spending all this money on these people in the first place? To prevent hospitalizations.
The dossier highlights that a single avoidable emergency room visit costs a Medicare Advantage health plan somewhere between $200,000 and $3,000 per incident.
$3,000 for one weekend escalation.
A patient's weight creeps up because of fluid retention. Nobody catches it on Friday. They can't breathe on Sunday. They call an ambulance, and boom, $3,000 gone in 48 hours.
And that is just the immediate ER triage. If they're admitted as an inpatient, that number skyrockets into the tens of thousands.
So what this means mathematically is catastrophic for the enterprise. Look at what you are doing with your resources.
You are taking a highly skilled $140,000 a year clinician, and you are functionally turning them into a chauffeur for 40% of their workday.
A chauffeur with a master's degree in nursing.
Literally. They are staring at a steering wheel instead of a patient.
So if you calculate their effective hourly rate for actual clinical care, the moments they're actually utilizing their medical training, that rate isn't $67 an hour. It's astronomical.
The financial bleeding in these capitated, value-based models doesn't come from the preventative visits. It comes from reactive ER admissions.
Because we are tying up our best, most expensive assets in traffic, they physically cannot intercept the patient in time.
It's a completely reactive posture masquerading as preventative care.
The dossier categorizes this rot in the system using lean principles. For those familiar with manufacturing or Six Sigma, you'll recognize this. It breaks down the inefficiencies into brutal categories of waste, or MUDA. First up is transportation waste.
Which is the most obvious one? Moving a patient to a clinic or moving an NP across town to ask a patient standard intake questions adds literally zero biological value to the patient.
Right. Driving does not improve their heart function. It does not lower their blood sugar. It is pure logistical friction consuming half your operational budget.
And then there's the overprocessing waste.
This metric blew my mind. According to the analysis of current models, primary care providers spend nearly 2 hours on electronic health record, or EHR, documentation for every 1 hour of direct patient care.
Let that ratio sink in. 2 hours of data entry for 1 hour of medicine.
It's absurd. The clinician, this person who spent a decade in higher education learning how to heal the human body, is acting as an outrageously expensive data entry clerk just to satisfy administrative billing requirements.
It's the definition of overprocessing. You are over-engineering the documentation to capture revenue, but in doing so, you are destroying the capacity of the very asset generating the care.
And my quote-unquote favorite waste, if you can call it that, because it's actually the most tragic, is the defect waste.
Which manifests in this system as alert fatigue.
Right. We have all these tech-enabled networks running predictive models. Everyone loves to talk about their proprietary AI risk algorithms.
And these models take in all this data, and they just raw risk flags onto the dashboards of these $65,000 a year community health workers.
The system flags 300 patients as high risk on a Tuesday morning without any actionable triage workflow.
Which completely paralyzes the operational layer. Imagine being that community health worker. You log in and your screen is blinking red with hundreds of names.
It's a nightmare.
It is mostly false positives. So what do? You start making manual phone calls. You spend hours calling patients who don't actually need help.
Maybe their blood pressure spiked because they were watching a stressful football game, not because they are in crisis.
Exactly. And because they are tied up making those 50 useless phone calls,
they miss the one silent escalation of the patient who actually does need immediate intervention. The one whose lungs are filling with fluid.
It is a catastrophic defect in the workflow. And the human cost is massive staff burnout. These workers are emotionally exhausted, feeling like they are constantly failing, leading to massive attrition.
Okay, so you take all of this, the fixed denominator of traffic, the massive numerator of human salaries, the crushing burden of transportation, overprocessing, and defect wastes, and the dossier calculates a metric to define this failure.
It introduces something it calls the ID10T index.
I just love that name, ID10T, like the old IT joke.
Right, an ID10T error, meaning an idiot error or user error. But here, they formally define it as the inefficiency delta index.
How does this index actually work?
It basically measures how fragile a service delivery system is to infinite scale. It looks at the ratio of marginal costs to marginal revenue as you add patients.
And what does a high score mean?
If you score 100 on this index, it represents total systemic failure, meaning the larger you grow, the faster you go bankrupt, because your operational complexities multiply faster than your efficiencies.
And where do these legacy in-home value-based care models sit on that scale?
They score perilously close to 100. They are structurally doomed at scale.
Because you were attempting to optimize a mechanism that is fundamentally flawed at its core.
Exactly. So what are all these venture-backed startups doing wrong? They have smart people working there. They're trying to build better logistical software to manage fleets of cars for nurses.
Building better routing algorithms.
But as the Dossier so perfectly puts it, that is the equivalent of investing billions of dollars to make a horse-drawn carriage 5% more aerodynamic.
That is such a striking analogy. We are putting wind tunnels on stagecoaches.
It completely misses the fundamental physical limits of reality. An aerodynamic carriage is still pulled by a horse. A highly optimized nurse still has to sit in traffic.
Wow. Okay, so if the system is pouring billions of dollars into building tools for the billing department and AI scheduling to optimize the doctor's calendar, it is completely missing the actual reality of how and where care actually happens.
Which brings us to a massive glaring blind spot that the manifesto points out. We ignore the true job executor.
Yes. This is where the dossier pivots from critiquing the current model to analyzing human behavior.
The legacy healthcare system operates on a deeply flawed assumption. It assumes the physician owns the healthcare utilization journey.
Wait, explain that. The doctor doesn't own the health journey.
No, the dossier vehemently argues this is a fallacy. The physician owns a 15-minute transactional slice of the repair journey.
Think about it. You go to the doctor, they diagnose you, they write a prescription, they bill the insurance company, and the transaction is closed.
But health is not a transactional event. Health is a continuous environmental state.
Health is a continuous environmental state. That is such a powerful first principle. You are healthy until you are not. But your biological trajectory is dictated by the 99.9% of your life that is spent completely outside the physical presence of a medical professional.
Exactly. You live in your home, you eat your food, you navigate your stress. So the question becomes, if the doctor's only there for 15 minutes every few months, who is actually managing that 99%?
Who is the actual job executor keeping the patient alive day to day?
And the dossier introduces us to a persona it calls the informal family quarterback.
I want you listening to really picture this person because odds are you know them or you are them. This is typically an adult child, usually a daughter in her late 40s or 50s, or a healthy spouse.
And let's be clear about their qualifications. They generally do not have a medical degree. They are accountants or teachers or retail managers.
Right. And crucially, they do not care about the payer's actuarial math. They don't give a damn about risk adjustment factor scores or capitation rates or downstream clinical savings.
Their core job, the thing keeping them up at night, is entirely different and deeply personal.
It's maintaining the physiological and environmental stability of a vulnerable family member in the home.
That is their mandate. And they are operating in the dark.
It's the overwhelmed daughter trying to manage her mother's dementia or her father's congestive heart failure. Let's call her Sarah.
Sarah is suffocating under administrative red tape.
She is taking time off work to coordinate Medicaid transportation, which is notoriously unreliable. She is dispensing complex cocktails of daily medications. She is arguing with the pharmacy over prior authorizations.
And here's the economic reality that the health plans fail to grasp. If Sarah burns out, if she brays under the logistical and emotional weight of this unpaid labor, what happens to the patient?
The patient defaults to the emergency room.
Immediately. If Sarah can't manage the medications, the father misses his diuretics, his lungs fill with fluid, and someone dials 911.
And the moment that happens, the health plan's entire actuarial math collapses. The profit margin for the whole year is wiped out by that single ambulance ride.
Which is why the dossier makes this incredibly bold statement. Protecting and empowering this informal family quarterback is the single most effective cost containment strategy a health plan can possibly deploy.
Not building more clinics, not hiring more doctors. Empowering Sarah.
But to empower her, You have to actually understand her life. You have to map her friction.
And the author does this meticulously by mapping out a 9-step chronological job map for managing chronic decline.
Let's walk through this grim reality step by step. Because when you see these 9 steps laid out sequentially, you realize just how much we demand of people who have absolutely zero clinical training.
Let's walk through it. What does the beginning of this journey look like?
Step 1 is define. The family has to define the baseline health status. Dad just got home from the hospital after a heart scare. What is his new normal? What are his dietary restrictions? What is he supposed to weigh?
Then, step 2, locate. Sarah has to locate specialists who take his specific Medicare Advantage plan and locate community resources like maybe a specialized food bank or a senior day program.
Step 3, prepare. Preparing the environment. Buying the shower grab bars, organizing the 7 different pill bottles into those little plastic daily organizers, making sure there's low-sodium food in the pantry.
Notice that in those first 3 steps, no actual medical care has been administered yet. It is entirely logistical and administrative setup.
Exactly. Then we get to the daily grind. Step 4, confirm. Confirming upcoming appointments, confirming that the transportation service is actually going to show up tomorrow at 9 a.m.
Step 5 is execute. Executing the daily biological care, helping Dad out of bed, ensuring he actually swallows the pills, getting him into the car for the doctor's visit.
And then we reach step 6, which the dossier identifies as a massive critical failure point.
Monitor.
Yes, monitoring continuously for silent escalations, checking his weight every morning, checking his blood pressure, trying to figure out if his ankles look more swollen today than they did yesterday.
Step 7 is modify. Modifying routines based on those symptoms. If his blood pressure is high, does she give him an extra pill? Does she call the nurse line and sit on hold for 40 minutes? Step 8 is resolve. Trying to resolve acute flare-ups at home before dialing 911. Panicking at 2 a.m. because he is coughing. Trying to decide if this is an emergency or just a cold.
And finally, step 9, conclude. Concluding the home care phase or transitioning a patient to a skilled nursing facility or a hospice when it becomes too much.
9 brutal, relentless steps. And the cycle repeats endlessly.
It's exhausting just reading it.
Now, you mentioned step 6, monitor, as a critical failure point. How do we actually know that? How does the dossier prove which of these steps is breaking the system?
The dossier devotes a significant section to what it calls the unified validation engine, and it is a masterclass in how healthcare gets data science wrong.
I completely geeked out over this part, I have to admit, because it entirely destroys how the healthcare industry usually measures success or patient satisfaction.
Yes, the dossier is highly critical of the standard 1 to 5 Likert scale surveys that every hospital uses.
The ones that ask, on a scale of 1 to 5, how satisfied were you with your visit today?
Exactly. The author calls the reliance on averages from these scales statistical malpractice, which is a strong but remarkably accurate phrase. Let's explain why.
Please do.
If you ask 100 caregivers how hard it is to get a doctor on the phone, and 50 of them rate it a 1, meaning it's absolutely terrible, they are crying in frustration, and the other 50 rate it a 5, meaning it's perfectly fine. If you average those scores, what do you get?
You get a 3.
You get a 3, a fictitious mathematical mean. The hospital executive looks at that 3 and says, well, a 3 is fine. We are average. No need to panic.
That average distorts the actual distribution of human pain. It tells you absolutely nothing about the 50 people whose lives are falling apart and who are about to send their parent to the ER.
It's like reviewing a restaurant where half the customers got food poisoning and the other half had the best meal of their lives.
Right. If the restaurant has a 3-star average, it completely hides the fact that you have a 50% chance of going to the hospital.
Exactly. So the dossier rejects averages entirely. Instead, they demand what they call State 3 empirical proof using the top box formula.
Okay, let's break down the top box formula for the listener. How does it work?
Top box means you only care about the extremes, the 4s and 5s on the survey. You ignore the middle completely. They calculate a metric called the urgency gap, represented by the variable G.
Walk us through a specific example from the analysis.
Let's look at the task of coordinating transportation. If you survey 1,000 caregivers about how important it is to coordinate transportation reliably, and 85% of them rate its importance as a 4 or 5 the top box, it is highly important.
Makes sense. If Dad misses the dialysis appointment, it's a disaster.
Right. But then you ask them about their current satisfaction with how the system handles transportation, and only 15% rate their current satisfaction in the top box.
Okay, so 85% say it's critically important, but only 15% say the current solution is working.
Precisely. To find your urgency gap, your G-score, you simply subtract satisfaction from importance. 85 minus 15 means your G-score is 70.
Wow. And the dossier states that any G-score over 50 means a market expectation is structurally broken.
A score of 70 means the market is screaming in pain and is completely ripe for disruption.
But the analysis is rigorous, so it doesn't stop there, because the author acknowledges that self-reported importance surveys are inherently flawed.
They are susceptible to inflation bias.
Meaning, if you ask an exhausted, sleep-deprived caregiver what is important, they are going to say everything is a matter of life and death.
Exactly. To them, the pharmacy hold time feels just as critical as the actual medication. So to bypass that emotional bias, the dossier calculates something called derived importance.
This is represented by the variable R, which is the Pearson correlation coefficient.
Okay, we're getting into the statistical weeds here. Before we apply it to healthcare, let's explain the R variable in plain English. What does a Pearson correlation coefficient actually tell us?
Let's use a car analogy. If you want to know what causes a car's engine to seize up and die, you could survey drivers. But instead of asking their opinions, you look at the raw data.
You correlate specific maintenance behaviors with the ultimate failure of engine death.
If you find that failing to change the windshield wipers has an R correlation of 0.1, it means there is almost no relationship. Wipers don't cause engine failure.
But if you find that failing to change the oil has an R correlation of 0.9,
it means that if you don't change the oil, engine failure is practically guaranteed. They move in lockstep.
exactly. A score of 1.0 is perfect correlation. Now, apply that to the dossier. The system's ultimate failure, the engine dying, is the avoidable $3,000 emergency room admission.
The author correlates the caregiver's satisfaction with specific tasks on that 9-step map against the rate of ER admissions.
And what did the data reveal?
When they looked at step 6, the task of minimizing the necessity of human intervention to monitor daily vitals, they found that the correlation, the R variable, approaches 0.85.
In behavioral science, that is practically a law of physics.
It is incredibly high. It proves unequivocally that the inability of the family quarterback to easily and reliably monitor a patient's vitals like daily weight for heart failure is the exact mathematical root cause that leads to the hospital trip.
Wow. So it's not just that Sarah is annoyed by having to weigh her dad every day.
No, it's that failing at this specific mundane task mathematically guarantees the catastrophic failure of the entire systemic model. The data is literally screaming at us.
It's telling us that the root cause of biological failure isn't a lack of medicine.
The pills exist, the surgeries exist, the root cause is administrative and logistical suffocation. Sarah just can't keep up with the data collection.
Correct. The bottleneck is human data collection.
Okay, so if we have the math, if we know exactly what step is breaking the system, how is the multi-billion-dollar healthcare industry currently trying to fix it? Because according to the manifesto, they are running in the exact wrong direction.
The dossier outlines two distinct false saviors that everyone, venture capitalists, private equity, hospital boards, is throwing money at right now.
Let's look at Pathway A persona expansion, which they also call the lateral move.
Pathway A is your classic, unimaginative corporate M&A growth strategy. Mergers and acquisitions.
Let's say you have a value-based care model that works relatively okay in a small, highly dense urban area. You have a few clinics, you know the local market. So the board says, let's grow. Let's sell the exact same product to new personas in new geographies.
Right. We conquered downtown, let's go conquer the suburbs.
You buy up rural independent primary care practices, you add new clinical specialties like nephrology, and you expand your management services organization, the MSO, into entirely new ZIP codes.
It sounds so safe to traditional executives. Buy more clinics, acquire more patients, generate more revenue.
Why is this a false savior? Why doesn't this solve the problem?
Because scaling a fundamentally inefficient human-dependent model doesn't multiply your margins. It multiplies your friction exponentially. Let's start with geography and the denominator of physical travel. In a dense urban setting, a community health worker might drive 10 minutes between apartment buildings. They can hit their maximum of 6 visits a day. But if you execute Pathway A and expand into a rural environment...
Oh, wow. They might drive 60 miles between high-need patients.
Exactly. The physical denominator stretches. That same $65,000 a year worker might only complete 2 visits a day now. Your unit economics are instantly destroyed by the highway system.
And what about telehealth? People always say, just put an iPad in the rural home.
The dossier addresses that directly. It notes that rural Medicaid populations often have broadband penetration rates below 65%. You cannot deploy basic telehealth infrastructure if the patient physically cannot connect to the internet.
So the physical expansion fails. What about the back end? Tying up all these independent clinics must create economies of scale for the business, right?
It creates technical debt that is devastating to the enterprise. Think about the reality of buying 5 independent family practices in different towns. Every single one of those clinics operates on a different, completely siloed legacy EHR system.
One uses Epic, one uses Cerner, one uses eClinicalWorks.
And they do not like to talk to each other.
They actively resist talking to each other. So now you want to run your fancy predictive AI to figure out who is going to the hospital. Your AI needs social determinants of health data, SDOH,
Things like food insecurity, housing status, transportation access.
which are coded completely differently in every system.
Exactly. Integrating that data across these legacy silos takes, according to the Dossier, an average of 9 to 14 months per system.
9 to 14 months per hospital system just to get the databases to shake hands.
It is an absolute nightmare. You aren't building innovative healthcare software at that point. You are just paying armies of consultants to build expensive API bridges so your predictive models don't ingest flawed data and accidentally send your nurses to the wrong houses.
And the cost. The upfront capital expenditure, the CapEx, is massive. You are signing 10-year commercial leases for brick-and-mortar clinics. You are floating the operational losses-paying salaries and rent for 18 to 36 months of actuarial validation just to secure downside risk contracts from the government.
Pathway A scales fragility. It has a competitive defense timeline of practically 0 months.
Meaning anyone can copy you.
Exactly. Any competitor backed by a larger private equity fund can replicate your exact strategy simply by offering a higher acquisition multiple to the clinic across the street. You have no proprietary technology. You are just buying top-line revenue at the catastrophic expense of your balance sheet.
Okay, so if Pathway A, the physical real estate roll-up, is a trap, what about Pathway B? This is the tech industry's absolute favorite solution right now. Every conference is buzzing about this.
The Dossier calls it the sustaining trap and AI co-pilots.
Let's walk through the logic. If the nurse practitioner is spending 2 hours charting data for every 1 hour of actual patient care, let's just fix the charting. Let's give them a generative AI scribe.
It sounds so logical. You put a listening device in the room, the AI transcribes the conversation, formats the SOAP note, and compresses that 2 hours of administrative paperwork down to 20 minutes.
Boom. We just freed up hours of the clinician's day. We saved the enterprise millions of dollars, right? What a vision.
That is the naive mathematical assumption made by technologists who don't understand behavioral economics. And it introduces what the Dossier argues is arguably the most dangerous psychological trap in healthcare logistics today.
Which is?
The Jevons paradox.
The Jevons paradox. Okay, we need to spend some time unpacking this because it is fascinating and applies to so much more than just healthcare.
The concept originates from a 19th century economist named William Stanley Jevons. He was studying coal consumption during the Industrial Revolution.
Engineers had just invented much more efficient steam engines that used far less coal to produce the same amount of power.
So the logical assumption was, great, our overall coal consumption in the country is going to plummet.
Because each machine needs less fuel.
Exactly. But what actually happened was the exact opposite. Because steam power became so cheap and efficient, every single industry suddenly adopted it. They built 10 times as many factories. And total coal consumption skyrocketed.
It's the highway traffic analogy. When a city has terrible traffic, the government says, let's add 3 more lanes to the highway to reduce congestion.
But making the highway wider makes driving easier, so more people decide to drive instead of taking the train.
And within a year, the wider highway is completely gridlocked again. You induced more demand by making the resource easier to use.
Precisely. Making a resource cheaper or more efficient mathematically increases its overall consumption. Now let's apply the Jevons paradox to our AI scribe in the clinic.
If you use AI to increase a clinician's capacity from 4 visits a day to 8 visits a day, the enterprise does not suddenly save 50% of its labor costs.
No, because the enterprise simply books 8 visits. They fill the schedule.
And this is where the specific demographics of the patient population become critical. We have to factor in the extreme elasticity of vulnerable populations.
The Dossier identifies a demand elasticity factor of 2.5 for these patients. It classifies their demand as hyperelastic.
What does that actually look like in reality? Why is their demand so elastic?
You have to look at the psychological reality of the demographic. We are talking about elderly, often low-income patients managing chronic diseases. They suffer from profound social isolation, loneliness, and health anxiety.
Right. They are scared and they are alone.
To them, an in-home visit or a telehealth call with a compassionate nurse isn't just a clinical checkup, it is a vital human connection.
So if you use AI to drop the friction of that interaction, if you make a free, at-home human connection effortless and perfectly efficient, they will utilize that service infinitely.
They will call the nurse for non-acute loneliness, for minor aches, just have someone to talk to.
Wow. So if the friction drops, the volume explodes exponentially. You didn't save money. You inadvertently turned your highly paid medical staff into a social lifeline.
And suddenly, you are forced to hire more $140,000 NPs just to service the artificially inflated demand for human connection that your efficient AI system just created.
The volume threat is very real. It's like opening a fire hose.
But the paradox creates a secondary, even more fatal consequence. The Dossier calls it a bottleneck shift.
If you give the frontline MPs an AI scribe and they double their daily throughput from 4 to 8 patients, what happens downstream in the compliance workflow?
It instantly crushes the L4 senior reviewers.
Remember, by federal law, for CMS compliance, a primary care physician, the asset costing the enterprise $280,000 a year, must review and formally sign off on complex care plans generated by the MPs.
So if you have a team of 5 NPs and they suddenly double their daily visit volume because of the AI, they instantly double the volume of complex charts routed to the desk of the overseeing physician.
You didn't eliminate the overprocessing waste, you just violently shifted it from the front line right onto the desk of the most expensive, scarce asset in the entire company.
The senior physician's queue becomes an insurmountable backlog. They are drowning in perfectly formatted, AI-generated charts for minor ailments and social visits.
And while they are bogged down reading those,
Critical escalations, the patient whose lungs are filling with fluid gets lost in the digital pile. AI doesn't save money in a structurally flawed system. It just builds a faster, more expensive hamster wheel.
which leads to the ultimate, inescapable conclusion regarding these false saviors. The Dossier states, you cannot bank operational savings if the baseline mechanism of value delivery still requires a physical human presence.
As long as your denominator is physical travel and your numerator is expensive human labor, your margins will either flatten or completely invert as you try to scale.
It is a mathematical certainty.
Okay, so this is the valley of despair. If lateral M&A expansion fails and bankrupts us with tech debt, and AI copilots just induce infinite demand and crush our doctors, what do we do?
Do we just give up on value-based care? Here is where the Dossier completely flips the script. This is the visionary part I love. This brings us to segment 4, the innovation matrix and the disruptive vision leap, pathway C.
This is where Boysen's work moves from critique to architectural redesign. To fix a structural physics problem, you cannot just brainstorm on a blank whiteboard with sticky notes.
You have to force the problem through strict, defined innovation matrices to consciously invert your legacy operating assumptions.
The Dossier literally walks through these matrix triggers. Let's break them down. It says the legacy healthcare system relies on a combined architecture.
Meaning, the gathering of biological data checking the blood pressure is permanently physically combined with the presence of a clinician. So how do we use the triggers to break that?
The first and most crucial trigger is separated processing. We must completely decouple the data collection from the clinical analysis.
Think about how banking changed. You used to have to go to a teller or a human to check your balance. That was combined processing.
Then we got ATMs and then mobile apps. The data collection was separated from the human banker. In healthcare, the biological data has to be gathered ambiently and asynchronously, completely independent of the NP's daily schedule.
It happens in the background. And then there's the make physical virtual trigger.
We delete the car ride entirely. The concept of a visit ceases to be a physical event bounded by time and space. It becomes a continuous virtual data stream.
We also have to apply marketing triggers. The automate manual trigger, meaning we transition to trigger-based, logic-driven communications instead of relying on manual phone calls from exhausted health workers.
And crucially, the borrow leverage trigger.
Instead of spending $50 million building new neighborhood clinics and trying to build trust from scratch,
We leverage OPA, other people's audiences.
OPA, I want to come back to that because that is the secret weapon for scaling. But first, let's paint the vivid picture of what Pathway C actually looks like in the real world.
The Dossier calls it the labor inversion. We are shifting from a human-centric, high-touch model to a zero-marginal-cost preventative network.
What does a labor inversion actually mean for the staff?
A labor inversion means we structurally decouple revenue and value delivery from human operational expenditure. We are removing that $140,000 a year clinician from the routine data collection loop entirely.
They do not gather data anymore. The environment itself becomes the diagnostic engine.
The environment itself.
Okay, let's go back to our informal family quarterback, Sarah. How does Pathway C change her life and her dad's care?
Instead of asking Sarah to write down her dad's weight or sending a nurse to do it, you put passive, cellular-enabled hardware into the patient's home. A smart weight scale, a cellular blood pressure cuff.
And the economic magic here is the marginal cost. If I send a nurse to check a patient's vitals once a day, it costs hundreds of dollars. If I want them to check it twice a day, my labor costs double.
But with an ambient cellular scale. Checking a patient's vitals 10 times a day now costs the enterprise exactly the same amount of money as checking it once.
$0. The marginal cost of data collection drops to absolute zero.
Which fundamentally solves the absolute highest friction phase of the family quarterback's job map. Step 6, the monitor phase.
The dossier points out that we are no longer trying to build a better app to minimize the time it takes Sarah to monitor vitals. We are structurally engineering the system to eliminate the necessity of human intervention in the monitor phase entirely.
It is an elegant deletion of friction. If that elderly patient with heart failure gains 3 pounds of water weight overnight.
The ambient scale detects it instantly the moment he steps on it to brush his teeth.
Yes. Sarah doesn't have to remember to log it in an app. The NP doesn't have to sit in rush hour traffic to discover it.
The network captures the anomaly asynchronously.
And because the data collection is zero marginal cost, the expensive human NP is preserved, safely stationed in a centralized command center, and deployed only for acute validated escalations.
This is how you absorb the Jevons paradox. I see it now. The hyperelastic demand, the patient's desire for daily reassurance and check-ins, is handled by the passive algorithm, not the human.
The patient feels constantly monitored and safe, but the enterprise pays nothing for that feeling.
You completely break the linear relationship between patient volume and human clinical headcount. You can scale to 1 million patients without hiring 1 million nurses.
Exactly. You achieve true scale.
Okay, so this vision is incredible. It makes perfect economic sense. But here is the massive pitfall. How do you actually build this without making the classic health tech mistake?
Because I've seen startups pitch this exact vision, raise $50 million, and go bankrupt a year later because nobody used their devices.
This brings us to segment 5, the Wizard of Oz execution. The dossier issues a severe warning against what it calls the monolithic fallacy.
The monolithic fallacy is the primary reason the healthcare software graveyard is filled with massive, beautiful, predictive platforms that have 0 active users.
It happens when leadership commits massive capital, tens of millions of dollars, to build the entire back-end architecture, the machine learning models, the perfectly integrated apps, before they ever prove that the core logic actually solves a behavioral problem for the end user.
Right. They invent adoption metrics in a boardroom, they forecast linear savings on a spreadsheet, they build the Death Star, and then they launch it.
And Sarah doesn't want to use it because it's too complicated.
And the investment is totally lost.
Yeah.
To execute Pathway C safely and avoid this trap, the dossier outlines a methodology called real options deployment. It's a concept borrowed from financial engineering.
You treat your research and development budget not as a massive upfront capital sink, but as purchasing a series of small strategic options to systematically reduce uncertainty.
I love this. Instead of walking into the board meeting and asking for $10 million to build an AI platform, you ask for $50,000 to prove a single specific behavioral mechanic. You stage your bets.
Exactly. So phase 1 is the option to explore. You do not write a single line of code. You conduct deep Socratic interviews with just 15 high-need family quarterbacks.
You're just validating the first principle. Is monitoring vitals actually their biggest pain point?
You just talked to 15 people. If they say no, you pivot. You only spent a few $1,000s on coffee and gift cards.
If they validate it, you purchase the next option. Phase 2 is the option to validate. Now you need statistical significance. You survey 400-plus caregivers across different demographics using that unified validation engine we discussed earlier.
Demanding the top box empirical proof. You need to see that objective need score cross that 0.40 threshold or a G-score over 50.
Correct. You need mathematical proof that the market is bleeding. Once you have that, you move to phase 3.
The option to execute. And I have to tell you, this is my absolute favorite detail in the entire dossier. It is so scrappy and brilliant.
They do not build an expensive automated app. They don't hire a team of developers.
They build an MVPR, a minimum viable prototype.
The Wizard of Oz method.
Yes. Walk us through how a Wizard of Oz prototype actually works in this context.
The goal is to test the behavioral intervention, not the software. So you go by 50 basic off-the-shelf cellular weight scales.
No Bluetooth pairing required, no Wi-Fi passwords to remember, because seniors and complex caregivers hate configuring Wi-Fi.
Just a scale that connects to a cell tower the moment you put batteries in it, you give them to 50 patients.
And behind the curtain, back at the office, you don't have a multi-million-dollar AI engine processing the data.
You have a single, highly trained nurse practitioner sitting behind a basic dashboard watching the raw data stream come in.
The NP is the man behind the curtain.
Precisely. If a weight anomaly hits the dashboard, the NP manually types out an SMS text message on a keyboard, sending it directly to the caregiver's smartphone, but phrasing it as if it's an automated system.
They are pretending to be the AI. They are testing the human reaction to the intervention. Can a simple text message from an algorithm actually divert a physical ER visit?
Let's walk through that triage workflow in action, because it beautifully highlights the genius of the automate manual logic gate we talked about in the Matrix. Let's say the ambient scale detects a 3-pound overnight weight gain in Dad.
That is a massive red flag for acute heart failure.
The system, or in our prototype, the Wizard of Oz NP, fires off a text to Sarah. We noticed a 3-pound weight increase for your father. Did he have a high-sodium meal last night, or is he currently experiencing shortness of breath?
Just a simple binary text, and if Sarah replies, "Oh yeah, we had Chinese takeout last night, high sodium," what happens?
The system logs the context. It realizes the weight gain is dietary, not a cardiac failure.
Yeah.
It resets the baseline. And think about the economics of what just happened.
Zero clinical OpEx operational expenditure was consumed. No nurse had to drive to the house.
The hyperelastic demand for reassurance was absorbed completely by a text message. The patient and Sarah feel continuously supported, but the enterprise pays literally nothing for that interaction.
It is brilliant. You only route the escalation to a real human voice if Sarah replies, "Yes, he can't catch his breath." Then the MP immediately calls them and triages.
Exactly. The algorithm filters the noise. And if this manual, scrappy MVPR proves that a simple SMS intervention can divert, say, 30% of expected ER utilization over a 90-day period, you've won.
The unit economics are sound. You have empirical proof. Then and only then do you earn the right to ask the board for the $5 million to fully fund the back-end automation and replace the Wizard of Oz MP with actual code.
Because you eliminated the behavioral risk before building the technology.
Okay, so let's say we built it. The tech works. The text messages are preventing ER visits. This leads us directly into the ultimate market reality and how a company builds a defensive moat against competitors.
Because having a good idea isn't enough. You have to protect it. The Dossier makes a fantastic point here. Market adoption is never, ever about having a clever marketing campaign. It is entirely about eliminating human friction.
Absolutely. The dossier includes a great external FAQ section designed to clarify exactly what the patient experience looks like and why it strips away all friction.
Let's look at the financial friction. What is the out-of-pocket cost to the family for this ambient cellular monitoring equipment?
$0.00. It's fully subsidized by the capitated health plans because the plan knows saving one ER visit pays for 500 scales.
What about technical friction? Do they need to install Wi-Fi in their rural home?
No. The devices have built-in encrypted cellular SIM cards. They run on the AT&T or Verizon networks in the background.
Are there confusing portals to log into or apps to download?
Zero. Just a standard SMS text message that pops up on the phone they already use every day. It literally replaces a 2-hour logistical nightmare of calling, waiting on hold, and driving with the 5-second text message reply.
That is how you drive patient adoption. But we must address the other side of the equation, provider resistance.
Historically, physicians violently reject new tech platforms. They hate black box algorithms because algorithms traditionally generate massive alert fatigue.
Right, the defect waste we talked about earlier. Doctors don't want a system that sends them 100 false alarms a day. Why wouldn't they reject this system?
Because this architecture structurally uses the family quarterback's SMS replies as a contextual filter. The doctor does not see the raw data. They don't get an alert just because the scale spiked.
The doctor only gets an alert routed to their desk when the ambient sensor detects a biological anomaly and the family confirms via text that there is acute physiological distress.
The system eliminates the noise for the doctor.
Exactly. The clinicians are protected. They only deal with highly billable, top-of-license emergencies that actually require their medical expertise. When physicians realize your technology is actively protecting their bandwidth instead of draining it, the resistance evaporates. They will champion your platform.
Okay, now let's talk about the moat, because this ties back into the OPA, other people's audiences trigger we mentioned earlier. Let's look at the competitive landscape.
If you are a legacy company using Pathway a competitor backed by private equity could copy your clinic acquisition strategy in 0 months. Just outbid you.
If you were using Pathway B, writing an AI scribe wrapper, a tech competitor could copy your software in 3 months using open source models. How does Pathway C create a 5-year defensive moat that nobody can cross?
It creates a moat on 2 fronts: data and trust. First, by physically embedding cellular hardware into thousands of living rooms, you are building a proprietary longitudinal dataset of ambient SDOH markers that no legacy hospital system possesses.
Hospitals only have intermittent clinic data. You have continuous home data. That is incredibly valuable. But the go-to-market strategy is the real impenetrable moat.
This is where OPA comes in.
Yes. To bypass the grueling, expensive 5-year timeline required to build community trust from scratch.
Because let's face it, if a giant faceless healthcare corporation rolls into a marginalized neighborhood and says, take this free medical device, we are here to help, the community is understandably going to be deeply skeptical.
Highly skeptical. It usually requires building multi-million-dollar neighborhood hubs and spending years doing community outreach to overcome that.
But Pathway C says, don't build trust, borrow it.
You partner with local faith leaders, you partner with local barbershops, you partner with the independent community pharmacist who has been on that corner for 25 years.
Precisely. You use existing, deeply trusted community infrastructure to distribute the hardware.
The onboarding doesn't come from a corporate suit. It comes from local health advocates, pastors, or pharmacists who already deeply understand the neighborhood's specific cultural challenges.
Hey, Mrs. Johnson, take this scale home. It's going to text your daughter and keep you out of the hospital. If the pastor says it, she believes it.
It drastically accelerates the implementation timeline. It drops the customer acquisition cost, the CAC, down to near zero. A competitor cannot replicate decades of local community trust just by spending VC money on Facebook ads. That is a 5-year moat.
And the financial exit strategy for investors is the absolute cherry on top of this entire model.
If you are a legacy value-based care model, the one sending nurses in cars, you are fundamentally a services business. You are limited by human labor.
So when you go to sell the company, Wall Street values you as a services business. You exit at maybe a 1x or 2x revenue multiple.
Which is standard for high overhead service firms. But Pathway C, you aren't a service firm anymore. You have transformed the business into a highly defensible, zero-marginal-cost data platform.
You move from a 1x or 2x services valuation to an 8x, 10x, maybe even 15x SaaS platform multiple.
And by the way, for anyone listening, we're pronouncing it SaaS today. You get that SaaS multiple because you now own a proprietary continuous data stream that massive technology conglomerates or retail health giants are desperate to acquire.
You have orchestrated health at zero marginal cost.
What an unbelievable journey this dossier takes us on. From realizing the physical, mathematical limits of a highly trained nurse sitting in a Honda Civic in rush hour traffic, to discovering how ambient cellular scales and simple Wizard of Oz SMS logic gates can literally save lives, prevent burnout, and generate billions of dollars in enterprise value.
The synthesis, the real so what for you listening today, is profound. We often think of innovation as purely additive. Building a faster app, adding AI to a workflow, making a flawed analog human process run 10% faster.
But what Boysen shows us is that sometimes true innovation is subtractive. It is having the structural courage to delete the human process entirely where it mathematically doesn't belong.
You remove the human from the data collection.
So that you can preserve human empathy for the exact critical moment it is needed most. The nurse isn't exhausted from driving. They are sharp, alert, and ready to save a life when the algorithm finally calls them.
I absolutely love that. Delete the process where it doesn't belong to preserve the human where it does.
So, as we wrap up this deep dive, I want to leave you with a final provocative thought to mull over today, whether you work in healthcare, logistics, software, or anywhere else. Look around your own industry. Look at your own P&L. What incredibly expensive, highly trained human asset is currently being used as a glorified, exhausted data collection sensor? And what would happen to your margins and your team's sanity if you had the courage to let the environment collect that data instead? Think about it. We'll catch you next time on the Innovation Unpacked Deep Dive.